easier when we will have equipped our new research and training laboratory, which we have already started to build. We need also the collaboration of the companies and the institutions to get more equipment, mannequins, simulator, and supplies for this process of training. I hope we will have it very quickly. In summary, from 100% of patients without arterial imaging for peripheral arterial disease, we build a vascular surgery program within the vascular activity. Now we intend to open the laboratory and open new horizons, implementing both difficult, but we think now we can share it with the colleagues and go further. Thank you for your attention.
I think he deserves another round of applause for his persistence. Yes. May I invite all the three speakers upstage to answer the questions?
My first question is on the AV access. When you have the complication of the Still syndrome, how do you go about the management? I want to know. Then the other one is on the training. What is your program like in South Africa for the first-class surgeon? Do you do general surgery first before first-class surgery, or you go straight to first-class surgery?
Mine's more of a few comments. We have an actively developing practice on AV fistulas, various vascular access. It's on page 25 of the abstract book, abstract number 13. And I want to just point out a few things that we have as challenges to compare to your practice. When we first started, we were doing mainly blind using the landmarks, but central lines tend to be ultrasound guided, and I've taught all my trainees now to do ultrasound guided, and I found that using ultrasound guidance makes it easier, more reproducible. They're looking at the vessel, they punch it directly, they can get it going. Second thing is, I found that the AV fistula first was what we always advocated, but your point about the access team, the team working together is so important. We've had to work with our nephrologists and ask them, please preserve one of the limbs. Most patients who came to us initially had all the veins battered, so it was a nightmare getting access. So in those cases, we often had to put in an internal catheter. These days, we put an internal catheter at the same time we do the fistula, because that way we find that it helps to protect the fistula. The nurses at dialysis centers would not intervene too early before it matures. We have a higher chance of the fistula getting to maturity. We've also done about a quarter of our patients doing basilics because they have no other access. So we do the basilic, but we do a transposition. So we bring it and superficialize it. But also the aftercare. Though we are surgeons, if you do a fistula or external catheter and it gets cocked up, it's your failure. So what we do is every patient who we do a external catheter for, we give a vial of heparin, and we train them and tell them how it should be flushed following each dialysis session. That way, in our early practice, it was just 4 or 5 months, boom, it's gone. But these days, a year, 2 years, they're still using the catheters if required. And we also try to gauge who needs a fistula first, who needs a external catheter. If they're on a bridge to dialysis, to a bridge to transplant, and there's a chance of getting transplants early, we just put in the external catheter and they go for their transplants. If they're going to be long-term access, then we do the catheter first to protect the fistula, and long-term they have the AV fistula. Thank you.
I think my interest in this is because I was putting in most of the tunnel lines in the hospital for about 10, 15 years. Now we have nephrologists who are doing them, so I've actually stopped. My main question is, can you thrombolize your tunnel lines when they are blocked? And then do you have any place for thrombolysis for blocked divisions?
All right, management of steel. I'm going to suggest to you that there are some novel ways in which you can deal with it by creating bypasses around it, and some things have not been proven. But I'm going to suggest to you that if there is a steel and the hands are ischemic, then take down the fistula. I've seen this all too often, that you can have residual nerve damage in people that have kidney disease. But if you have rest pain in the hand, please take down the fistula. I think it's behoven us, and I've seen patients that walk around with paralyzed hands by people that fiddle around and try and do anything novel. Do you want to say something? The training of, you'll talk about, yeah, ultrasound guidance. I mean, I think that's not a bad idea, but in the face of where we are in medicine today, I think we need good science and good endpoints as to whether ultrasound guidance has a clinical benefit. And I haven't come across a paper, and I've looked for it, suggests that if you puncture blindly, if you get in the first time, that's any worse or better than using ultrasound. So if you're not used to it, ultrasound guidance can become cumbersome. And if you're doing many of these, if you understand anatomical endpoints, then that shouldn't be a reason not to do this. Access team, I think, is very important. Your relationship with the nephrologist is of critical importance. I mean, you know, if you don't talk to the guy, if he doesn't know what your capabilities are, you don't stress on the point that patients need to be sent early for native fistula access, you run into trouble. There was another point. Yes, the issue around damaging veins. And we can't seem to get around this, even in the private sector, which is more regulated, that phlebotomists, people that take blood, we've gone to the extent of actually placing little placards all over the place to please indicate that you should not, in a patient who's suffering from renal failure, puncture anywhere near the antecubital fossa. But they will go for the biggest vein, which is the one that you need to create a fistula. It's easy for them, etc., and they literally damage this. And at a guess, I think they decrease the patency rates by up to 30% by doing this. So more than the nephrologists, you know, sort out the phlebotomists. Yeah, thrombolysis has been documented. There's lots of publications on how you deal with this. And I have shown you a case of using Actylase in the periphery, but I'm going to make a point that if you are an astute surgeon and you can perform a cut down properly, you're better off performing an embolectomy than actually placing a thrombolytic catheter. The only difference is one needs a cut down and the other is performed by a radiologist, which is so-called minimally invasive. But you can get rid of a whole lot of clot with a simple embolectomy catheter. Remember that these patients are sick. They have a tendency to bleed because of platelet dysfunction. You have to give them heparin during the dialysis phases. So inserting a thrombolytic catheter and then trying to monitor them is a problem. You would tend to do this if there's a native fistula, and then if you have the capabilities of actually dilating the vein and tending to sort it out. But remember, if there's a block in a native fistula, a lot of that clot is old. It's been there for a long time, and it's just been built upon. So the only place is in a graft, in other words, a PTFE graft, which you can easily clean out with an embolectomy catheter.
Dr. Mahdi, just very quickly about training in vascular surgery in South Africa is still based on general surgery. It is a recognized subspecialty of general surgery and requires a 2-year fellowship. So very much still the American model. I guess it's a matter of time before we will have a separate training in vascular surgery in our country. It's a politically difficult situation. The view is that certainly our regulators are very keen on generalists and not specialists and subspecialists, but I think that that's going to happen in time. You alluded to the need to differentiate or who does what within vascular surgery. Our view is that cardiac surgeons in our country are probably more adept at managing patients if they require cardiopulmonary bypass. And for that reason, when the patient clearly requires cardiopulmonary bypass, we will ask the cardiac surgeons to do that surgery. We are, however, very comfortable operating on the ascending aorta. If the patient doesn't need to, go through that whole process, we wouldn't in vascular surgery replace the arch because of the need for cardiopulmonary bypass. But anything beyond that, we will generally do it, and we often will do it in conjunction with them. The area that's been a particular interest is the whole endovascular revolution, and largely as a result of a logistic situation where the interventional radiologists and the interventional cardiologists had much greater opportunities in other fields. It has been the ambit of the vascular surgeon to do the endovascular work. And in fact, we believe that A vascular surgeon needs to learn all techniques and that they can apply the best form of therapy to the patient at the right time.
Thank you very much. May we have the next set of questions, please?
I'm really greatly enriched this afternoon by this workshop, and thank all the speakers. I have two questions to Professor J. What really determines the size of the atherectomy at AV fistula? I've observed that the most difficulty I face is when, especially when I attend to female patients. They most of the times have small vessels. Suppose I find a very small, less than 3 millimeter vein, can I increase the length of the atherectomy to be longer so that there will be increased flow? Or what do I do? Secondly, if I have a patient that has severe renal failure, very anemic in cardiac failure, can I still go on to do the AV fistula? Because I wonder if the flow increases, that may worsen the cardiac failure because of overload or something like that. Thank you.
Thank you very much. My question is on the vascular trauma. Over 5 years, we've managed close to 30 cases of peripheral vascular trauma. And our challenges has been the issue of the patient presenting to the first contact physician unaware that the patient may have vascular trauma, especially when associated with other injuries. And that increases the warm ischemic time. These are our challenges, and most of the time, patient may end up with amputation. I don't know what's your own experience. Then my other question is, in your area, is it the vascular surgeon or the orthopedic surgeon that does the amputation? Thank you.
Thank you very much for this time. First of all, I want to just mention about some things we do with our chronic venous catheters. I mean, the palm cats that get thrombosed. We've been using streptokinase, and we try to sort of centralize the bottle, because a cost for a vial might be too much for a patient sometimes. So you keep it and just use the amount you use and charge per use, and then subsequently use for other patients. That has helped to a large extent in clearing some of the thrombosis in some of these catheters. And then there is another group of patients who we observe that tends to clot much more easily. And we've tried to pull them on 1 milligram warfarin at the initial time, combining with heparin, and then subsequently after the initial 72 hours, we just leave them on 1 milligram warfarin. And probably that helps also to reduce the rate of thrombosis in some of these catheters. Then the next thing is the issue of management of complication, because now we've been having patients now who have been on fistulas for a very long time. They come with, because of improper cannulation at dialysis, they have a lot of aneurysmal presentation, some with stenosis, and these are the current challenges we are beginning to face. And with the kind of resources we have, we are really facing a great challenge. What do you suggest as the way forward?
We have problem with extensive use of anticoagulation, especially the unfractionated heparin that needs monitoring. And in some of our patients, the difficulty of monitoring them has pushed us to use fractionated heparin, the enoxaparin. I would want you to share extensively your experience with the use of perioperative anticoagulation, especially in trauma cases. And do you really use enoxaparin at all in the place of unfractionated heparin?
Thank you very much for the presentation. Some of my questions actually have been raised by some of the others, but I just want to put in perspective a little bit. You talked about 3 millimeters for the anastomosis. In our center, we don't use 3 millimeters. We find that rather too small, narrow. So we tend to go for something much higher. We tend to aim for up to close to 1 centimeters. Because maybe because part of the challenges, you see, we did have a lot of problems. I remember, I think we had our first try at AV Fistula 2006. We had a lot of failures. Our failures rate was quite high. When you look at the veins, most of the veins were very bad. In fact, that brings to mind the second question I have in my mind, and that is, what do you do after you finish your anastomosis and it's pulsating rather than a trill? And then you have a patient, like in our center, you can't refund the money to the patient. The patient has to pay, and the surgery has been done. Patients, that's it. We don't have facilities for any kind of balloon dilatation. And many of the patients, either at the presentation, in fact, we have put together our work, which we hope to publish quite soon. We have many patients, more than 40, 50, have had some kind of central venous access. They've had some kind of central venous access, and so they have some kind of obstruction. So what do you do on table? Do you stop the surgery, close the veins, and then maybe hope for tomorrow? Then lastly, this is just like a comment. One thing we noticed in our center when we started passing central lines some years back was that there was a very high rate of thrombosis. But just one little observation has cleared it for us. And that what we found out that most of the patients who have thrombosis, because of the cost of dialysis, their dialysis rate was very low because they are paying from out of their pocket. So some of them are having dialysis once in 2 weeks, and so they are not having heparin locks. And maybe some things like that. And in fact, we have also noticed that there's a higher incidence of infection among those same patients because they are rated in the hospital.
I'm going to deal with the veins. There's this reasonable amount of evidence that suggests that you will receive success with a vein of about 3 millimeters and an arterial inflow of 2.5 millimeters. And the figures are put up with 3 and 3 just for convenience. The only comment to make is that what we have been doing with small veins, even if they're around 2 millimeters, is to dilate them with a PTA balloon, so a longish PTA balloon without fluoroscopy for about 30 seconds. So it tends to dilate the vein much like you would do a saphenous vein, in other words, when you dilate it before bypass. There's some evidence that it works. You must just be careful not to cause endothelial damage when you're doing that. Yeah, the fistulae that, it's very difficult to actually prove that a fistula is causing a high output cardiac failure as opposed to the patient being overloaded or has intrinsic myocardial damage. It's generally believed, however, that fistulae in the sizes that we create do not lead to this problem. In any case, patients are dialyzed and they tend to get rid of that excess burden of fluid. Yeah, streptokinase in dialysis catheters, I mean, the clots that have been documented and the ones that we see are a bit of clot at the tip of the catheter. Now, I know this has been shown, but I've failed to understand how streptokinase actually solves the problem. Clot is quite old, and I wonder whether what actually works is that you loosen the clot and then shoot it into the lung, and that's how you clear the catheter. Because, I mean, it's just, it's not intuitive, but there are some case reports. When the catheter is blocked, we tend to change it immediately. So we place a new one, and we assess the superior vena cava to look for a stenosis and dilate that at the same time. And I think that answers the last question. Yeah, there's some data to show that low-dose warfarin may clear underlying hypercoagulable state. However, there are two problems that cause clotting. One is the hypercoagulable state. In other words, fistula with normal anatomy may go on to clot, but the other fistula that may have some problem. In other words, aneurysmal dilatation, intimal hyperplasia. In the latter case, we tend to use Plavix, clopidogrel. In the former, where there's a hypercoagulable state, we'll either give low-dose warfarin or monitor warfarin for full therapeutic use. In other words, an INR of between 2 and 3. Yeah, well, look, AV aneurysms, I suppose there are two types. One is a dilatation with a stenosis in a functional fistula where there isn't an impression of impending rupture. It looks horrible, it's cosmetic effect, but in fact, if it's functioning, we'll leave it alone. In other words, we'll try and dilate the outflow tract to improve patency, but we will leave it alone. The other end, if you get the impression that the fistula is eroding through the skin, then that area needs to be replaced with a synthetic graft or another vein. Yeah, I dealt with that. Central venous obstruction, usually the SVC or the brachiocephalic is dealt with purely at endovascular means. So we perform a venogram at the time when the catheter is changed, and if there is a stenosis, we'll deal with it, usually by PTA without stent placement. Once you place a stent around a vein that has an outflow obstruction, you'll create more problems. So even if you repeatedly dilate it, and now we're using drug-eluting balloons to do this, you'll probably receive an adequate result.
If I then address the question about the trauma and the prioritization of vascular trauma, I think that most of those really identify themselves. You know, the vascular trauma that's hemorrhaging and is life-threatening will obviously be addressed before anything else. The problem is often where that vascular trauma is bleeding into a cavity, and the difficulty in deciding particularly whether one should explore the thorax or the abdomen first. Bottom line is that most people today will probably go into the abdomen first because that's mostly a survivable injury. But imaging certainly is of great benefit, and the use of a rapid ultrasound in the emergency room, the so-called FAST, often helps. The situation in terms of whether to address a vascular injury first and then allow the orthopod to fix or vice versa, I think is a moot point. Most of us would want to address the vascular injury first, and we will sit around and watch the orthopod like a hawk while they're putting an external fixator, something of that nature. In South Africa, vascular surgeons do their own amputations, and that certainly, as pointed out earlier, takes away a lot of that difficulty in terms of deciding when to do it and how to do it. The question around anticoagulation is a vexed one. The question of whether one should use a longer-acting anticoagulant because of the risks related to subsequent hemorrhage. There's no doubt that the anticoagulants with longer half-lives, in fact, are more effective. It appears that we do not monitor and do not manage the more rapidly acting anticoagulants adequately, and again, it's the balance of what effectively achieves the best outcomes. And we are quite comfortable for that reason to use low molecular weight heparins. We only use unfractionated heparin in acute arterial ischemia currently. And in fact, we'll reverse the low molecular weight heparins using protamine as we would with unfractionated heparin. The area where I think it becomes much more interesting is the use of antiplatelet agents and dual antiplatelet agents, and particularly in our world, clopidogrel or ticlopidine, where in fact the data now is that if you have to operate on those individuals, that operation can be done. Our cardiac surgeons at times are quite comfortable to do a cardiac operation in patients on dual antiplatelet agents, recognizing that they're going to be in greater difficulty. And we, for instance, will in acute surgery also do that. But for instance, in carotid surgery, we now would not consider doing the operation unless those patients are on dual antiplatelet agents because of the safety, and will accept that there will be some form of hemorrhage or a slightly higher rate of hemorrhage. The usual issue again is let's look at the broader picture and the wider outcomes than to look at the ones that worry us most.
Okay, thank you. I have a question. Are you using ultrasound landmarking before AV fistula? Because sometimes it helps decide if it will be easy or not.
Yeah, there's some good data to show that helps. In other words, merely assessing the size and the patency. We don't routinely use it because we feel that even if the vein is small, in about 40 or 50% of patients, it'll still work. So it's not going to give us any more information. I'll just make a comment about the trauma and, if I may, the anticoagulants. There isn't a randomized study looking at the perioperative use of anticoagulants, in other words, low molecular weight heparin versus unfractionated heparin. But there is a randomized study by a guy called Geertz, G-E-R-T-S. In fact, it's a landmark study that looked at unfractionated heparin versus low molecular weight heparin in trauma patients admitted to ICU. And low molecular weight heparin was, in fact, the drug of choice. So trauma patients, your drug of choice is still low molecular weight heparin if based on that single study.
Thank you very much to the three doctors who have given us very brilliant lectures. And I've actually suggested, through the questions you've asked, one topic for the next meeting. And I'd like you to give them a round of applause to appreciate what they've done for us. Thanks again.
Thank you very much, Dr. Iduayi, Professor Martin Vella,